Good morning. I think this is very important to discuss about cardio-oncology. This has become a specialty of its own, and it all started almost about 10 years back, and this has really taken off, and a lot of engagement with imaging. So I'm going to start off with a case. This is a patient who has lived cancer for 10 years. She was diagnosed over 10 years. Stage 3 breast cancer, and now comes back with a very complicated course of disseminated carcinomatosis. And you can see the long list of cancer-related therapies that are known to cause cardiotoxicity, which includes adjuvant therapies, erythromycin, trastuzumab, so on and so forth. So if you see the images now, what you realize that you're dealing with a very complicated course where there is also a likelihood of not just peritoneal or pleural spread, but also pericardial spread. You have the left ventricle, right ventricle, and you're asked to give assessment about, besides the pericardial effusion, what do we think and what should we do about it? So some of the diastolic function. What stands out very importantly is look at how abnormal the tissue Doppler filling pattern is, relaxation pattern is. And you can see a very strong IVRT wave, which has got basically prolonged, and this is the E wave, the A wave, and you have evidence of there being myocardial relaxation abnormality, and that's also translated when you do the global longitudinal strain assessment. Clearly, even if the ejection fraction, which is calculated as 52%, looks like borderline, your longitudinal strain is remarkably attenuated. The global average is hovering around 15%. And 15% happens to be somewhat lower number, and typically the question always comes up is what is the number that you're going to use in the clinical practice? And for that, we start looking back and examining different questions that are emerging in this particular case. So ejection fraction 52%, the GLS looks reduced. And the questions that are coming up is this patient with disseminated carcinomatosis, what do we do with Herceptin? We know that Herceptin can prolong life. And what do we do next? What will be your communication with regards to an abnormal strain? And how should you manage? Maybe start cardioprotective therapies. No cardioprotective therapy is indicated. Just continue to follow the patient, stop Herceptin, or refer the patient to a cardio-oncologist. And just I'm going to go with this example of what typically has evolved very currently in the guidelines. So there are two guidelines, and in both the guidelines, global longitudinal strain has been incorporated in decision-making. But the first question that comes up is what is a normal global longitudinal strain? And typically, we use a value that is 18% or higher as normal, but the threshold of 16% probably accommodates some of the variability that comes in related to loading changes. The blood pressure has a relationship with the normal longitudinal strain. So 16% or lower, 15% or lower is clearly an abnormal longitudinal strain. And there are two guidelines that came up in the last couple of years. One is the European guideline, and one there is also an American heart failure guidelines. And the question in these guidelines is not about how do you treat cardiotoxicity, but how do you embrace cancer survivorship. So the natural history of cancer-related cardiovascular dysfunction evolves, and you would see episodic change in the cardiac function that is related to the acuteness of the therapies. And then there is this long-term change that leads to development of heart failure. So after having an estimation of the baseline risk, low risk to a high risk, the whole idea is to ensure that we can look into a long-term plan of cancer survivorship, which is free of cancer-related cardiovascular dysfunction. So there are two terms that come often, and one is cancer therapy-related cardiovascular toxicity, and the other one is long-term development of dysfunction, cardiac dysfunction related to cancer therapies. So the toxicity could be episodic, but the cumulative toxicity over the time leads to cancer therapy-related cardiovascular dysfunction. And how do we approach that? Is in 2020, it was the establishment of several risk factors or risk scores. And one of the ones which has been established and been accommodated in the guidelines is the Heart Failure Association and International Cancer Oncology Society risk score. And what it does is it classifies people into low, moderate, high risk, and a very high risk. And this is further adjudicated for each of the drugs that you prescribe. And there are very key ways to approach it. For example, if you would have a patient who's on Herceptin targeted therapies, you would look into a very high risk factors as someone who has heart failure, clinical heart failure, or a high risk factor could be previous coronary artery disease, MI, LV ejection fraction less than 50%, elderly. And then you have all these other points for medium risk factors with 2 points and medium risk factors with 1 point each. But cumulatively, when you use some of this algorithms that are then incorporated into the guidelines, and if you have a low risk person, someone who has got one medium risk factor or no risk factors, typically just a routine oncology therapy and is required, and you don't need to send all of these patients to a cardio-oncologist. If there's a moderate risk or a very high risk, you need a cardiology referral, and a closer follow-up on these patients are indicated. And it has been established in the guidelines that while left ventricular ejection fraction continues to remain a powerful predictor and is used specifically in people who are asymptomatic, use of three-dimensional ejection fraction, 3D echo-derived ejection fraction, or if it is 3D cannot be done, then biplane 2D or other MRI whenever the echo is not available or not good in quality. It is also incorporated that strain has been shown to have significant prognostic information. And there are several small studies where certain therapies like trastuzumab can be carried out even if the patient has an evidence of underlying LV dysfunction, which is borderline or in a mid-range ejection fraction. So in this particular case, for example, you would have a heart team discussion with the cancer team, and it was decided that the patient would continue with the underlying neoadjuvant therapy, and then you keep on having follow-up. Now, one thing which really comes out strikingly is the number of follow-ups that have been recommended in the guidelines. And it seems like these patients in the European guidelines have to come up so frequently that I think there has been a debate whether this is practically feasible. But nevertheless, follow-up is recommended, even if it is not monthly or 3-monthly. And in this particular situation, strain is monitored. The only randomized controlled trial that guided the use of cancer therapies along with cardioprotective therapy guided by strain was actually a negative study. And this is the Sucker study, where patients who had one risk factor or more risk factors were were followed up. They were started on cardioprotective agents. And if the GLS went down by 12% from the baseline, or if there was a 5% reduction with symptoms, or 10% reduction in ejection fraction, with even if the patient was asymptomatic. And on follow-up, there was no change that was seen in terms of development of cancer-related cardiotoxicity, cancer therapy-related cardiac dysfunction. And one of the criticism was that this trial was designed before all of these new guidelines have come through, and there was a use of a lower threshold, 12% instead of the 15% or more, and clinical heart failure was not taken into consideration. So the jury is still out, and we continue to use still strain. And there are multiple clinical trials on the horizon that are still examining the use of strain and ejection fraction. But the whole idea is to look into, once you have cancer therapy-related cardiac dysfunction, how do you move forward? And you can have symptomatic heart failure or asymptomatic heart failure. And in the guidelines, if someone has symptomatic heart failure, you stop the medication. Or if there is asymptomatic, and you can interrupt the medication only if there is a significant change. And of course, they continue with heart failure therapies. But in this particular instance, the patient was continued. And, this is what ended up happening, severe LV dysfunction. The patient subsequently, was staged, and a heart team discussion was made. The patient continued deteriorating and, of course, decided to go a palliative and hospice route. But this is eminent, and the literature continues to evolve. And one of the important areas for consideration right now is with the AI-developed tools for automated GLS. How do we enforce the quality in the strain imaging? And how do we reduce the variability related to vendors, which still continues to be a concern. And there is still literature that is evolving, but I think the future is going to be how do we integrate the risk factors that have gone into the guidelines into a way we can put the whole story together, because there is not just clinical risk factors, but also biomarkers and the echocardiographic finding. And this area is very, very fertile for application of AI. So there are high hopes on the evolution of more personalized therapy using AI-based tools. GLS and AI-based application will help us standardize. There is a lot of use of MRI, particularly with the newer drugs, with myocarditis that comes up frequently. So if this field continues to evolve, and there will be a continued engagement with the imaging community, and we just have to stay very open to this evolution. And this is becoming a very interesting field for the imaging community. Thank you very much.